Dear Professor Braunwald, dear Eugene, I just presented in Greek how I feel, and it's not only me, because you are not only the mentor at Harvard in the US, you are the mentor of all cardiologists around the world. We feel you as the mentor, and during the introductions, during the previous, the dean and the chair of the school and all the others, they just said some in Greek and some in English how they feel. The dean of the school is also of the medical, who is also cardiologist. Allow me just to say a few words, because we have among the attendees and among the virtual attendees some who are not cardiologists, and let me present who is Eugene Braunwald. Eugene Braunwald is the Distinguished Hersey Professor of Medicine at Harvard Medical School and the founding chair of the TIMI study group at the Brigham and Women's Hospital. Dr. Braunwald trained at New York University School of Medicine, and his medical house staff training was at Mount Sinai Hospital and Johns Hopkins Hospital. He served as Chief of Cardiology and as Clinical Director of the National Heart, Lung and Blood Institute, and then as Founding Chair of Medicine at the University of California, San Diego. He was Chair of the Department of Medicine at the Brigham and Women's Hospital, Harvard Medical School for 25 years, and from 1980 to 1989, he served simultaneously as Chair of Medicine at Boston's Beth Israel Hospital. Dr. Braunwald's first cardiology paper was published in Circulation Research in 1954, and he has been a major force in the field since then. His early work focused on the control and assessment of ventricular function, and he was the first to measure both left ventricular ejection fraction and left ventricular DPDT in patients. His group described the first neurohumoral defect in human heart failure, defined the pathophysiology of hypertrophic cardiomyopathy, and demonstrated salvage of ischemic myocardium and improved clinical outcome in patients with myocardial infarction whose occluded artery were opened, leading to the widely accepted open artery concept. He was also the first to show improved survival in such patients with ACE inhibition. Dr. Braunwald was the founding chair of the TIMI study group, and as you know, TIMI study group is an academic research organization that has conducted 70 clinical trials involving 350,000 patients worldwide. He demonstrated the benefit of intensive reduction in LDL cholesterol. We had long discussions earlier today about this. He was the first to prove this in the benefit in high-risk coronary disease patients, which changed everyday clinical practice and saved many lives. Science Watch listed Dr. Braunwald as the most frequently cited author in cardiology with an H index of 229. Dr. Braunwald served as an editor of Harrison Principles of Internal Medicine for 12 editions and is the founding editor of The Heart Disease, now in its 12th edition. These two textbooks are considered to be the most influential in their respective fields. He was president of the American Society of Clinical Investigations as well as the Society of Chairs of Medicine. He has received numerous honors and awards, including the Distinguished Scientist Award of the American College of Cardiology, the American Heart Association and the European Society of Cardiology, and the Copper Medal of the Association of American Physicians. He has received Lifetime Achievement Awards from the Heart Failure Society of America, the Heart Failure Association of the European Society of the Heart Failure Society, the European Society of Cardiology, the American Association for Thoracic Surgery, and the American College of Cardiology. The Brigham and Women's Hospital named its major bed tower and a research center in his honor. Dr. Braunwald received an honorary Doctor of Science degree from the University of Oxford, and he is the recipient of honorary doctorates from 23 other distinguished universities on 3 continents. Harvard University established the Eugene Braunwald Chair in Medicine. He was the first adult cardiologist elected to the National Academy of Science in the US. The American College of Cardiology and the Heart Failure Association of the European Society of Cardiology have established annual lecture in his name. All the living Nobel Prize winners in medicine voted Dr. Braunwald as the person who has contributed the most to cardiology in recent years. For this reason, and because we all feel you, dear Professor Braunwald, dear Gene, as the mentor, as the one who changed the cardiology this century, we give the Distinguished Personality Award in recognition of your contribution to cardiovascular medicine, your ethos, and your social and academic accomplishment. Thank you very much for accepting this award. You are muted.
Yes, can you hear me?
Yes, yes.
Good. Well, Professor, this is a tremendous honor for me. And let me tell you why it's such an honor. It's an honor because it comes from you and your accomplishments. It comes from Athens, it comes from Greece, and we hold Greek cardiology. We know that it's at a very high level and that there have been many contributions that have come from your department and from Greek cardiology as a whole. I think that the course that you have put together for this year, I've had a chance to look at the program, and it really does describe extremely well what's new in cardiology. I think your introduction of me was too kind and a little bit exaggerated, but I am very pleased to accept this great honor. And I look forward to hearing a lot of important things coming from your course, Professor Philippatos. So thank you very much.
Thank you very much, and we're looking forward to your presentation. Thank you, Professor Braunwald. Thank you, Eugene.
It is a great pleasure and an honor for me to speak to you at the beginning of this important and very important program on what's new in cardiology. And I'd like to talk to you about the war against heart failure. These are my disclosures. And I want to start really with the beginning of cardiology. William Harvey was an Englishman who went to school, medical school in Padua, lived from 1578 to 1657. He went back to London after he finished medical school and became a very prominent physician, but he was also a scientist. So he was the first physician scientist who did experiments both on patients and on animals. And there are two things that he said that are very important. He said, when I first gave my mind to discovering motions and uses of the heart, this is how he started. And this is in 1628 is when his book was published. I found the task so full of difficulties that I was almost tempted to think that the motion of the heart could be comprehended only by God. And that's a very important signal to all of us who do research, because sometimes, frequently, we come to problems that we can't solve. But William Harvey was undeterred. And at the very last, at the end of his monograph, he said that in chapter 14, it is absolutely necessary to conclude that the blood in the animal body, and that is the sole purpose of the contraction of the heart. So he put the whole story together. Now, why do I begin with this? I begin with this because 1628, it's only 6 years from now that we're very close to 2022, that we will celebrate the 400th anniversary of this great discovery. And William Harvey was not only a great scientist, physician of the 17th century, but he was also the first in biology to do hypothesis-driven research in any aspect of medicine and biology. So I think he was one of the great figures of the Renaissance. So I'd like to give you a timeline of the development of heart failure in what I call the war against heart failure. And it begins 70 years ago when I first was introduced to the problem of heart failure. I was a medical student in New York and seeing a lot of patients with heart failure at a large New York City hospital called Bellevue Hospital. Now, we had very little to offer these patients in 1950 when I was a student. Digitalis, as you see at the bottom arrow, and diuretics. Digitalis was thought to be a drug that improved cardiac contraction. Now, we're not so sure. It's given less and less. The diuretics were deep intramuscular injections of mercurochromate, which required a doctor to give the injection. And they were painful and they were not very powerful. The other thing that we did is we'd put patients on a low salt diet, and sometimes we had to do venesection, that is, remove blood from the circulation if they were going to go into pulmonary edema to reduce the preload on the heart. So it was extremely primitive. Now, the next thing that happened in this field was about 10 years later, and it was the Merck company that manufactured and developed the first thiazide diuretic, chlorothiazide, that we still use today. Now, that was a breakthrough. It was a breakthrough because it was a moderately potent diuretic, but patients could take the tablets at home. They didn't have to travel to the hospital. They didn't have to travel to a doctor's office to get an injection because they could only do that once a week. Every day, sometimes twice a day, they could take a diuretic, and it changed people's lives. And I have put a red ellipse around it because there are only 3 of these that I honor with a red ellipse because they really changed clinical management. So then we move into 1968. Christian Barnard, a daring and very skillful cardiac surgeon in Cape Town, South Africa, did the first cardiac transplantation. That was a wake-up call, because although not many transplants are done, given the huge field of heart failure, it showed that it is possible to take the sickest patients and prolong their lives. The opposite effect was loop diuretics. Furosemide, Lasix came along at the same time, 1968, and these, of course, were much more powerful than the thiazides, so it greatly enhanced the care of patients. In the 1970s, vasodilators became available. What we learned in the 70s was that patients with congestive heart failure very often were vasoconstricted, and that put an extra burden on the heart. And vasodilators opened that up and prolonged life. Now, 1980 is the introduction of ACE inhibitors, which were very important because they changed the whole attitude of treating patients with heart failure. They prolonged life. And I give them a red ellipse also, like thiazides. They really changed clinical practice. And of course, they were used for the treatment of hypertension as well. Now, in the 90s, came two other classes of drugs. The beta blockers, very powerful anti-heart failure medications, very useful at the present time as well, and angiotensin receptor blockers. They were a number of patients couldn't tolerate ACE inhibitors. They got coughing spells and they couldn't take it, but angiotensin receptor blockers have the same effect without the side effect. And now we move to a new millennium, the year 2000, and we have in the first couple of years several advances. From the top down, you see left ventricular assist devices, MRA, mineralocorticoid receptor antagonists. Then the devices are shown below in the year 2002, ICDs, implanted cardioverter defibrillators, and cardiac resynchronization therapy, CRT. And in the most recent decade, two additional advances, ARNI, angiotensin receptor neprilysin inhibitor. So this is more powerful than angiotensin receptor blocker. It has the effects of the blocker, but also blocks the destruction of vasodilating substances. So, and the one that is best known, of course, is sacubitril/valsartan. And then the third one are sodium glucose transporter 2 inhibitors, SGLT2I. And I put a red ellipse around that because that also is a major event. So here is really the experience I've had with heart failure. I've been very fortunate to have lived through these tremendous advances. I have had what you might call a ringside seat as these have developed. And sometimes I've gotten into the war myself, and it's always nice if you're in a war to be on the winning side. And on several of these, I was able to make some contributions to help win the war against heart failure. And I emphasize those three that I've circled: thiazides, which allowed patients to go home and to take adequate diuretics, ACE inhibitors, which prolonged life, and treated hypertension, and SGLT2 inhibitors, which I'm going to spend a few minutes on now. So I think you all know a lot about those. Professor Philip Bartels, of course, has been a leader, really a world leader in the study of SGLT2 inhibitors. So the British have a saying, you should never carry coal to Newcastle. That's because Newcastle in England is the center of the coal mines. And I have to be careful that I don't carry SGLT2 inhibitors to Athens, because Athens is the center for the development of these drugs. But I stay on the concept of heart failure. And without reviewing the entire field, which is very encouraging, I want to emphasize the two trials in which the SGLT2 inhibitors were studied on patients with heart failure only. The other trials had some patients with heart failure, some patients without. So the Emperor reduced was with empagliflozin, and the DAPA heart failure was with dapagliflozin. And here is an analysis of these two trials, which were remarkably similar. And this shows a meta-analysis. On the top panel, you see that the first hospitalization for heart failure or cardiovascular death, these were the primary endpoints of the two trials. And you see that there was a hazard ratio of 0.75. It means a 25% reduction in this endpoint in Emperor reduced, and a 26% reduction, identical really, in DAPA heart failure. So with two different SGLT2 inhibitors, and then you see in red the combined diamond, a hazard ratio of 0.74. Now, interestingly, if you look at the bottom panel, you see all-cause mortality. All-cause mortality was reduced significantly in DAPA heart failure. There was a numeric trend in Emperor reduced, but you see it crosses the line of identity. So it's not statistically significant, but when you put the two together, you see the hazard ratio of 0.87. That means there was a 13% reduction in all-cause mortality. Now, here is one of the most important papers, and you see Professor Philip Bartels right there on the top line, right in the center. And I have to compliment him on this very important paper on heart failure with preserved ejection fraction. Now, you all know that this represents about half the population with heart failure having preserved ejection fraction. And there has been no real effective treatment. We have treated around the edges. And this is a classic trial. And this paper, published a couple of months ago in the New England Journal and presented at the ESC meeting, was designed to look at a population of 8,000 patients. And the results really were spectacular. There was a 21% reduction in the primary endpoint, which was cardiovascular death or heart failure hospitalization. So I think that this is one of the triumphs of the war on heart failure. Well, one of the biggest puzzles now is what are the mechanisms of these tremendously beneficial effects on the heart. So on the top of this slide, you see the potential direct myocardial effects of SGLT2 inhibitors. The first is that they block sodium and hydrogen exchange. The second one is they reduce calcium calmodulin proteins, which have a negative effect on contractility. They alter autophagy and mitophagy in a beneficial way. They reduce inflammation, and the potential indirect and systemic effects are shown at the bottom of the slide. They improve renal function. They increase the number of progenitor cells. They increase erythropoietin and thereby increase the production of hemoglobin to improve cardiac oxygenation. They reduce the sympathetic nervous system to the heart and to the kidneys, and they improve cardiac energetics. And certainly working together, they tend to reduce heart failure, but which are the most important, whether they all are needed, is not clear at the present time. And I think a lot of research is going on, and I think that once we have this straightened out, I think it will enhance even further our use of these. So to come to a conclusion about this, there are four major paradigm shifts which have come from the SGLT2 inhibitors. First, these inhibitors are not only glucosuric, but they also reduce the development and progression of heart failure, and they prolong life in patients with type 2 diabetes and reduced LV ejection fraction. Secondly, these inhibitors improve outcomes in patients with heart failure, reduced ejection fraction, irrespective of the presence or absence of type 2 diabetes. This is very important. All of the findings that were first shown in diabetics are also seen in patients with heart failure without diabetes, and therefore this greatly expands the potential target population for these drugs. And it also shows us that we do not need to be diabetic to see this benefit. So the glucosuria probably does not play an important role. Thirdly, the SGLT2 inhibitors improve outcomes in patients with heart failure and preserved ejection fraction, as we just saw, and they are beneficial in patients with chronic heart failure over a wide range of ejection fractions, expanding the target population even further. And if all of this were not enough, the fourth major paradigm shift is one I have not had time to really discuss with you, but to indicate that SGLT2 inhibitors slow the development of end-stage kidney disease in patients with diabetic kidney disease. Now, diabetic kidney disease is the most important cause of chronic kidney disease and fatal chronic kidney disease in the world at the present time. So slowing this development is pretty important. The benefit of SGLT2 inhibitors in patients without type 2 diabetes, but with a variety of chronic kidney diseases other than diabetic kidney disease, appears promising and is under very active investigation. So these drugs are really fantastically valuable, and I would say the SGLT2 inhibitors are the statins of the 21st century. Next. Now, I want to say a few words about the most important cause of heart failure, and that's ischemic heart disease. And the most important cause of ischemic heart disease is a high cholesterol and high LDL cholesterol. So on this slide, you see plotted on the horizontal axis age in years, and on the vertical axis, the cholesterol burden, that is the cumulative cholesterol exposure. And it's calculated as the LDL concentration and how long that LDL concentration burdens the patient. So let's start off with the green line. And you see that there's a broken red line at the top, which is a threshold for the first clinical manifestation of coronary arterial disease. So basically that could be the development of angina, it could be the development of myocardial infarction, it could be a sudden cardiac death. And the number, the 105, is the LDL in milligrams per deciliter. And you see that line crosses the threshold at the age of 70. So we're saying if a patient for most of his or her life has an LDL of about 105, they can expect to have the first manifestation, not necessarily death, but the first clinical manifestation of ischemic heart disease at the age of 70. Now, if they are, look at the red line, if they're heterozygous for LDL receptors, they only have not two, but 1/2 the number of LDL receptors. You see the line is much steeper. They have an LDL of 200, almost twice that of the normal subject, and they intersect at the age of 35. So we know these patients, they come in, they have markedly elevated LDLs if they're not treated, and they develop often myocardial infarction at the age in their middle 30s. And then going all the way to the left, labeled LDL receptor negative are the homozygous, and these are subjects who have children, really, who have LDLs of 750 milligrams per deciliter, and their burden is enormous, and they don't need much time to reach the threshold, and often by the age of 10, they have had their first myocardial infarction. Now, it's possible to treat these. And if you take a patient, and this is why we have to discover these diseases early. If you take a patient who has heterozygous familial hypercholesterolemia, and you discover that at the age of 20, and put them on a statin that would reduce the LDL from 200 to 105. And you see then there is a new line, because the burden now continues to grow, but it grows at a much slower rate. They have gained 14 years. Obviously, if you begin the statin at the age of 34, they only have 1 year to go. You're not going to make much of a difference. If you were able to start that statin at a much younger age, then you would be able to postpone it. So it shows that you can manipulate the cumulative exposure. Next. Now, I think you probably have all heard about a new drug called inclisiran. Inclisiran is a drug that can be given by injection. Usually, it's been approved by the EMA in Europe. I don't know whether it's on the market in Greece or not, but it is given twice a year. It reduces the LDL cholesterol. It's been given by injection. It can be given on top of a statin. It can be given on top of it acts through the PCSK9 system. Now, one of the things that interested me is what happens if you give PCSK9 once a year. And this comes from a paper by Dr. Ray, who was a Timmy Fellow, who now is at Imperial College in London, who has looked at giving it once a year, and he studied 3 different doses. The dose that is widely used is 300 milligrams. And you can see that there is a rapid decline. And at the end of the year, there's still about a 25% reduction in the LDL. So if you gave another injection annually, you would produce an even lower LDL on average. And what I'm getting at is a treatment that amounts to just a single injection a year. And I want to give you, in closing, just one example. If we take for baseline a person who is 30 years old and who has an LDL cholesterol of 105, that's what I showed you on that previous slide, the one in green that goes all the way up until the age of 70, and prevent him by giving them an injection once a year together with a flu injection. Inclisiran, 300 milligrams per year subcutaneously along with a flu injection. And the effect of this is to produce an average reduction over the course of the year of 40% of the LDL-C concentration. And here is our patient, untreated at 105. That's the line that you saw before. And here is, we begin treatment and reduce the LDL by 40 milligrams per deciliter at the age of 30. And that allows him or her to reach the threshold 30 years later, not at the age of 70, but at the age of 100, and therefore it postpones the development of the most important cause of heart failure. Slide off. Slide off. So I've taken you on a journey, beginning with the history of our understanding of the heart that came from William Harvey. And then we talked about the incredible opportunities that I have had in my lifetime over 70 years to see a marked change in development of the treatment of heart failure. I call it the war against heart failure. And then finally have concentrated on that last battle of the war, the SGLT2 inhibitors, and how they have changed the field. So I want to thank you again for inviting me to participate in this important meeting, and I wish you all the advances in cardiology that will come from Greece. We look forward to our continued collaboration. Thank you very much.